the accelerated and comprehensive HIV care for epidemic control in Zimbabwe, which seeks to contribute to the national attainment and sustainability of HIV epidemic control in Zimbabwe, and is contributing significantly to the immense results that we're proud of today. The second and popular project is called the Determined, Resilient, Empowered, AIDS-Free, Mentored, and Safe, known as the DREAMS Project, which aims to reduce the HIV epidemic, particularly new HIV infections among adolescent girls and young women. I'm sure we are all very familiar with that. Adolescent girls and young women are actually a key population for control of the HIV epidemic. So these projects are implemented in Manicaland Province and Midlands Province, where various districts are actually supported, but also in Matabeleland Province as well. Now, coming to the purpose of our webinar today, I'm sure you are all familiar that cervical cancer is now the leading cause of cancer deaths among women in Zimbabwe. Not only is it a big problem in Zim, it's also a big problem among several other countries in sub-Saharan Africa and other low to medium middle income countries. And despite there being effective ways of preventing the disease, we have a number of women actually dying from cervical cancer in Zimbabwe every year. And if we look at statistics from the Zimbabwe National Cancer Registry, approximately 3,000 or so women are diagnosed with cervical cancer, and almost 2,000 actually die from the disease every year, which makes it quite a significant public health challenge in this country. So we also know that the WHO has envisioned a global strategy for the elimination of cervical cancer as a disease of public health concern by reducing the threshold to less than 4 per 100,000 women. And this is premised upon 3 pillars that are now known as the 90-70-90 strategies, which I think you are all familiar with. And so in this month of January, which is a cervical cancer awareness month running under the theme Learn, Prevent, Screen, we join the Ministry of Health and Childcare and various stakeholders fighting cervical cancer to raise awareness and lobby for the adoption of high-performance screening tests such as HPV DNA testing. Zimbabwe Health Interventions is hosting this webinar to increase awareness of cervical cancer and how it can be prevented and treated. So allow me to introduce the main speaker for the day, who is none other than Dr. Bothwell Guja. Dr. Guja is a qualified obstetrician and gynecologist who is also a gynecological oncologist in the country with qualifications from the University of Zimbabwe and also the University of Cape Town. He is also a minimal access gynecological surgeon, and he has extensive experience in gyne endoscopy. He's a lecturer at the University of Zimbabwe, and he's a principal investigator of several cancer studies hosted by the University of Zimbabwe Clinical Trials Research Center. And he is basically involved in teaching and running the multidisciplinary tumor boards that we hold at Perinatal Hospital, which he chairs, and is involved in several research projects with international collaborators like the International Agents for Research on Cancer. So allow me, ladies and gentlemen, to give the next 30 minutes to Dr. Guja to share with us his presentation, which is titled Cervical Cancer Elimination, a Call to Action. Dr. Guja, over to you. As Dr. Guja is presenting, if you've got any questions, you can note them in the chat box, and some of them will be addressed as we go by some of our experts who are here present, and some of them will be answered by Dr. Guja at the end of his presentation. Dr. Guja, you may go ahead.
Thank you very much. Thank you very much, Dr. Mreva, for the kind introduction. And thank you very much to ZHI for giving me this opportunity to give this talk in the month of cervical cancer awareness, which is a topic that I'm passionate about. So this is the outline of my talk. I'm happy that we are discussing about cancer today, because I think everybody in this webinar knows that cancer is now a big burden around the world. And what I found very interesting was this study done in 2013, which estimates that the lifetime chance of getting cancer in men is about 1 in 2, and in women is about 1 in 3. So 50% of men and 33% of women are more likely to get a cancer diagnosis in their lifetime. So this should give us a moment to pause and see how can we reverse this trend. I think it's a fight for our generation has to fight. I'm going to start off with a case that we presented in our tumor board in June of 2023, which is like a typical case that we see every day. This was a Mrs. EC, 56-year-old widow, who had well-controlled HIV for 20 years. So that means this patient was religiously attending their HIV care clinic. She had a postmenopausal bleeding and offensive vaginal discharge for 6 months. The sad thing is that she has been previously screened with visual inspection, and all her results were negative. However, in March 2023, the visual inspection was repeated and the lesion suspicious of cancer was noted. Biopsy confirmed squamous cell carcinoma. By the time we brought her to our tumor board, she had obstructive uropathy. She was now in renal failure with a very high creatinine. We referred her for palliative care. Unfortunately, this patient died 3 months post-diagnosis. This is what we still typically see in our government hospitals. Very sad, but I think nothing has changed over the past 20, 30 years in terms of how these women present. So that's why I'm so passionate about changing this trajectory so that we can pick these women at an early stage. So this is really, cervical cancer is a worldwide catastrophe. In 2020, 600,000 new cases were diagnosed and 340,000 women died from cervical cancer. And 1 woman dies from cervical cancer every two minutes. So if you want to make this vivid, is that imagine that a Boeing 777 crashing daily, that was meant to be for 2 years. So you wake up every day for the next 2 years, and on BBC, they're telling you that a Boeing 777 has crashed and it has killed all people on board. Imagine the fury, and I'm sure that this problem will be fixed in a matter of few weeks or a few months. But people are trying, but it's not, the death of women from cervical cancer is not getting this kind of, people are not really getting furious about this, because probably these are women that are dying. And the sad thing is that this disease is completely preventable. So if you see all those areas in dark blue, that's where you've got the highest incidence. And I think Zimbabwe lies in the eye of the storm with an incidence of about 213 per 100,000 women. If you look at women dying from cancer, Zimbabwe also lies in the storm. We're getting about 145 per 100,000 women. So we still have got a very high burden of cervical cancer and very high mortality rates from this condition. So what is the typical person that we see in our clinic every day? So majority of women that still come with cervical cancer to our hospital are women that come from rural communities. That's about 63%. And these women are diagnosed at a very young age, 46 years of age. So in medicine today, if you are trying to become a doctor and you go through medical school and you work for a couple of years before you specialize, and then you go and start specialize for about 3 or so years, you probably finish training when you're around 40, 41 years of age. And 46 years old, most people are still at their prime. And in this study done by Prof. Chirenge in 2000 showed that these women have got an average of 3 to 4 women who are dying from cancer, and the oldest being 24 and the youngest being 8 years. So these are left behind as young orphans before they've even found any meaningful employment or finished school. So this is really a tragedy. And majority of these women, 80% present at a stage that's not amenable to surgical treatment. So what causes cervical cancer? So one of the earliest observations in cancer epidemiology was that cancer of the uterine cervix rarely occurred among celibate nuns. So this led to the discovery that HPV causes cervical cancer, and HPV stands for human papillomavirus. It's a very common STI, which usually has no symptoms and is self-limiting. Almost all cases of genital warts and cervical cancer are due to HPV. And on top of that, HPV causes other genital cancers in women and men, including vaginal, vulvar, and yes, penile cancer, as well as anal cancer. I always tell women that HPV is like a flu that we get at the bottom, because 90% of people have HPV at some point in their lives. It's very common. Both men and women can get HPV. You can be exposed to HPV the first time you are sexually active from only one sexual partner. I think there was this lady called Jet Goody who was in Big Brother UK some time back, and she died from cervical cancer. She lives in a country where there's access to screening, and a friend here was saying, I feel guilty, I beat cervical cancer, and Jet Goody died. Were diagnosed at the same time, and they were diagnosed in their mid-30s. And I want to tell you that cervical HPV doesn't just cause cervical cancer. On the picture to my right there, there's a case of extensive warts, one thing that we see every day in our theaters. And on the right, those are abnormal cells that are looking dark in color that can lead to vulval cancer. These are cases that we see in our clinic caused from HPV, a massive case of vulval cancer. Similar case, massive case of vulval cancer. So when you talk about HPV, cervix is home, but this infection causes a lot of other HPV-related cancers in females and male. And sometimes the surgery is extensive. This is a lady with vulval cancer, and this is the extent of the surgery that was done, and she needed to have some flaps done to try and reconstruct, because the defect that was done after the operation was just huge. And yes, this is a man forced to have his penis amputated over what he thought was just a harmless rash. So yes, men can get penile cancer from HPV. So what are the other risk factors for cancer of the cervix? This includes cigarette smoking, use of steroidal contraception for more than 10 years, immune deficiency, especially HIV, transplant recipients, people on long-term steroids, and people receiving chemotherapy, and early sexual debut. There are 150 HPV types that have been identified. Out of those, 40 infect the genital tract, and they are both low risk that cause genital warts and high risk that causes cervical cancer. In most cases of cervical cancer, 70% of them are caused by HPV types 16 and 18. So HPV is very prevalent, and the prevalence is dependent on the age. In young women, 20 to 25 years, almost half of them can have an HPV infection, but it falls to about 5% in women above the age of 30. But if you take a woman with an abnormal pap smear, about 10 to 20% of them will be HPV positive. If you look at women with CIN2 and 3, up to half of them will have HPV types 16 and 18. And if you look at women with invasive cancer, 70% of them will have HPV types 16 and 18. So basically, you need HPV to develop cervical cancer. So if you look to the picture on my right, that's a woman with a high-grade lesion on your cervix. And if nothing is done, in about 10 to 20 years, these women would go on to develop cervical cancer. The duration is much, much shorter in women that are HIV infected. And risk of developing low-grade cells is about 6%. That's combining CIN1 and 2. And risk of developing low-grade cells is about 1%. It's about 17% of developing high-grade lesions, which is CIN2 and 3. Of note is that in HIV-infected individuals, CIN prevalence is 2 to 6 times higher, and progression to invasive cancer is more rapid, and treatment outcomes are poorer. And Zimbabwe has got a high burden of HIV, and this is very relevant to our setting. And I think I've already alluded to this, that about 70% of these cases are caused by HPV 16 and 18. I know if you look at somebody who's smoking, everybody frowns upon them because of the high risk of lung cancer in people who smoke. But if you look at the relative risk, the risk of developing cervical cancer in a woman with persistent HPV is actually much, much higher than the risk of developing lung cancer in a woman who smokes. So I thought I should just kind of like put this into context to see how carcinogenic persistent high-risk HPV can be. So what are the warning signs or what are the symptoms that someone is developing cervical cancer? So women can have an unusual vaginal discharge, abnormal vaginal bleeding, heavier and longer menstrual cycles, discomfort while urinating, pelvic pain, constant fatigue, pain during intercourse, loss of bladder control, unexplained weight loss, and leg pain. So if you develop any of these symptoms, I think it's prudent to go and see your healthcare practitioner. So how does HPV then end up as cervical cancer? So you start off with a normal cervix and you get HPV infected cervix, and more than 80% of individuals, their immunity will clear this HPV infection. Unfortunately, some women will progress to develop CRN2 or 3, and in about 10 to 20 years, they'll develop cervical cancer. So HPV clearance and regression depends on the age, degree of CIN, and the immune status. So like what Dr. Grant has alluded to at the beginning, WHO has now mapped a way to eliminate cervical cancer as a public health problem in the next 100 years. And I think if you look at these lines, if you look at the gray line, it means that if we continue with what we are doing now, we'll never be able to eliminate cervical cancer as a public health problem. But if you look at the blue line, just by vaccinating eligible girls, we should be able to eliminate cervical cancer as a public health problem by the year 2120. If we combine screening and intensive vaccination, we should be able to achieve this by the year 2090. So I want to argue, ladies and gentlemen, that we now have a roadmap of which we can use to eradicate cervical cancer as a gift to the future generations. Dr. Grant has already alluded to this 90% of girls being fully vaccinated against HPV by 15 years of age, 70% of women screened with a high precision test at least twice in their lifetime by the age of 35 and the age of 45. And 90% of women identified with cervical disease, either pre-cancer or cancer, receiving treatment and care. So there is a vaccine that can stop girls and boys getting 9 HPV types that can cause 90% of cervical cancers, most genital HPV-related cancers in males, and 90% of genital warts. This vaccine works best when given at the age of 9 to 14 before you become sexually active. So I want to just show this. I just want to show this. So I've already showed. So there are 2 ways of preventing cancer. One of them is actually to vaccinate girls or women before actually they get an HPV infection. And the other way is actually to identify women with abnormal cells through screening and treating them. And that is what we've been probably doing for many, many years. And we are still getting lots of women dying from cervical cancer. So I would like to argue, ladies and gentlemen, I think we should be taking vaccination very, very seriously. It's going to be one of the most effective ways of eliminating cervical cancer. So what is Zimbabwe doing in terms of vaccinating? So Zimbabwe is, if we were asked to do a midterm review of the Zimbabwe cervical cancer screening strategy in year 2020. So initially at the baseline in 2016, there were only 3% of districts that were offering HPV vaccination. And the target was to have 80% of them. But when we did the midterm review, we find out that 100% of districts in Zimbabwe offered HPV vaccine. So HPV vaccination program is sustainable due to the Ministry of Health commitment to co-fund payment of 20 cents per dose of the vaccine. And this is still ongoing. Girls are being vaccinated in grade 5 and grade 6. So our target for 2020 was 80%, and ladies and gentlemen, what we found when we did the midterm review was that actually Zimbabwe is vaccinating almost 90% of these girls. And these findings reveal performance beyond expectations, and success of HPV vaccination can only be ascertained when the vaccinated girls reach the age of screening more than 25 years. So we should be able to do studies to demonstrate that we have got a low prevalence of high risk of high-grade cells in women when these girls when they reach the age of 25. So these are the different screening methods that are available. You get visual inspection with acetic acid and cervicography, which is what the Ministry of Health at the moment is implementing. And in some settings, if there's no acetic acid, glucose iodine can be used for visual inspection. Cytology pap smear is available in the private sector. High-risk HPV is available in the public sector, and the Ministry of Health is going to be rolling out HPV screening probably from this year or next year, and you can get co-testing with any of these two methods. So those who work in cervical cancer screening, these are just pictures. For example, picture A, I'm just showing you how you put a speculum to identify your cervix, and these are the different type of instruments that you can use to take cells from the cervix if you want to do pap smear or liquid-based cytology or HPV testing. So WHO now recommends moving to HPV testing, and HPV testing can be used in different ways. It can be used as primary screening. That means women only get an HPV test on their first visit for screening, and if they are positive, they are recalled, and triaging can be done with either visual inspection, colposcopy, or other methods. You can, women that have pap smears in private, if they've gotten ASCAS or lost to pap smears, they can have an HPV test to determine who needs to have colposcopy or not. And like I've said, you can use HPV testing in combination with other screening methods like visual inspection, as well as cytology. And one of the uses of HPV testing is in women who have been treated, who are then brought back 6 to 12 months back to the clinic to do an HPV test to make sure that these women have been cured. So this slide, I'm going to skip over it, just explains to you the benefits of the differences between cytology, HPV, and visual inspection. But HPV requires trained lab workers, electricity kits, a transport system for specimens and results. So some investment will need to be made to have a successful transition to HPV screening. So if you happen to have cervical precancer or have a positive screening test, what are the possible treatment methods? So you can have a conservative where we either use some ablative techniques like cryotherapy or thermoablation to treat the abnormal cells on the cervix, or you can have those abnormal cells removed either through different procedures, either LEAP or laser conization or a cold knife. Normally in women that have got other gynecological indications for a hysterectomy, hysterectomy can be used as a treatment for CIN2 and 3 after colposcopy to exclude invasive cervical cancer. And in women with invasive cervical cancer, if it's diagnosed early, they can be treated with a radical hysterectomy, or for stages 2B to 4A, 4B, they can have radiotherapy. Chemotherapy is also now being utilized mostly in as a combination with radiotherapy or in palliative cases. And sometimes best supportive care or palliative care is recommended depending on the performance of status and the stage at presentation. So, ladies and gentlemen, I think my gist of this talk is to call people to action. I think we need to spread the word about screening. We need to spread the word that cervical cancer is preventable. So I'm very grateful for all the work that is being done by partners, ZHI and other partners that are involved in the space of cervical cancer screening. So I think one thing that you can do today after leaving this webinar is to spread the word that cervical cancer is preventable through screening. I think you can text 10 people in your contact list and remind them to get screened this week. Those people can send to other 10, and those 10 can send to other 10. And I'm sure that this will make such a big difference. No one is going to make a change for us, ladies and gentlemen. We are the people that we've been waiting for. So let's get going to encourage women to get screened. So what is the take-home message for my talk? Why does screening, vaccination, and treatment for pre-cancer and cancer matters? Because eliminating cervical cancer is about gender equity. Eliminating cervical cancer is about ending a cycle of poverty and protecting children. So this is unfinished business for the HIV movement, and eliminating cervical cancer will bring the world closer to achieving sustainable development goal 3 and 4 by the year 2030. Ladies and gentlemen, we can end cervical cancer. So get informed, find out the facts about cervical cancer and HPV that causes cervical cancer, help educate other women in your life too. I find it very sad. I see very young women, very educated, who get screening on time, they forget to pass on the message to their mothers in the rural areas, and they're bringing them to my clinic at Pari, they're bringing them to my private practice. And I'm like, how did you forget to tell your mom that she also needs to get screened? So guys, ladies and gentlemen, let's encourage people to get screened. And normally WHO now recommends screening to start at the age of 30. And I can't emphasize this more. We should get girls between 9 and 14 years vaccinated, but there's now evidence that even in older women, vaccination also helps to prevent infection with HPV and potentially reduce the risk of getting cervical cancer. So I think some people were saying during my talk, oh, what a bore. I stopped listening after 5 minutes. I need a wee. I think there were a lot of things that were going through our heads. Well, ladies and gentlemen, I'm sure my little talk has made you all think. Thank you very much for taking your time to listen to me. Thank you. I'll hand over back to the chair.
Thank you very much, Dr. Botho Guja, for such a passionate presentation. I think one of the things that really comes when you speak about this subject of cervical cancer is the passion, the drive to want to make a difference, the drive to want to make sure that no woman dies from cervical cancer, which is very much preventable. So thank you very much for taking your time and finishing ahead of time. That gives us a little bit more time for questions and answers and discussions. We need to, say, what are we not doing right? What can we actually do together collectively to make sure that we drive towards eliminating cervical cancer? What can we do to make sure that no woman dies of something that is so preventable? Where are we getting it wrong? What are we not doing right? What can we improve? So I will allow this time for questions, for comments. Those who want to speak, you can raise your hand and you will be identified and given the opportunity to ask or comment. If you also want to ask your questions in the chat box, you can do so and you will have your questions answered. Thank you. So yes, I'm waiting for questions now or comments, points for discussion.
I'm seeing some questions in the chat box. I don't know that they've been responded to.
All right, so the first question in the chat box says, my question is on high-risk HPV DNA. Is it being done here in Zim? And that can be answered together with another question that's saying, is a vaccine in a woman in their 20s useful, especially if they had sexual contact already?
Yes, so if I may answer that, I saw HPV testing is available, But at the moment, the Ministry of Health has agreed for Zimbabwe to move towards cervical cancer screening, but it hasn't been officially launched, those new guidelines. So hopefully in the not very distant future, it will be widely available. But at this moment, there are some partners involved in the cervical cancer screening space. They've been doing some pilot projects on HPV testing in various districts. So I'm seeing someone who already said that ZHI is supporting DNA screening in Makoni. But I'm sure that not very soon, HPV testing will be widely available as the primary screening tool in all the cervical cancer screening clinics in Zimbabwe. So, yeah, and the other question about vaccinating people in their 20s, yes, actually, the vaccine still works, even in women that are in their 20s. And one of the things WHO still recommends women in their 20s to be vaccinated. And you don't need to have an HPV test. Remember, there are about 13 to 15 types of high-risk HPV that can cause cervical cancer. It's rare to get someone being infected, unless if they're HIV infected by multiple types of HPV. So you can have one, you can have two. So definitely, even if you have one form of type of HPV, you can still get prevention from the other types that that would be negative at that point in time. So yes, women in their 20s can be vaccinated. The EMA in Europe at one time put a upper limit of age for vaccination is 45, and after that they put it at 55, depending on due to some studies that were being published. But now they've removed the upper limits for vaccination. But I think it's important to highlight this, that the vaccine is more effective if it's given before someone is becomes sexually active, but it's still effective in later years, but not as effective as when someone is not sexually active. So yes, I encourage women to still get vaccinated, even if they're in their 20s.
Thank you for your response. I'll also read a couple of questions here that can be answered together, and our partners from ZHI and other significant stakeholders here can actually help to answer these questions too. So is a vaccination effective for a 3-year-old who has not, I'm not sure if this is supposed to be 3-year-old or this is supposed to be another age. So maybe 30-year-old who has not been sexually active, what are the recommendations for her? Would there ever be vaccines made possible for boys, and is it financially feasible? And then funds permitting, would vaccinating boys help? So maybe you can answer these together, and we can also get help from other stakeholders in answering these, and then we'll go to the next question.
Thanks a lot, Grant. Thanks very much for those very interesting questions. So I think I've already answered the question about vaccination in 30-year-olds. So I think yes, they can be vaccinated. And is it feasible to vaccinate boys? So I want to emphasize that this vaccine works for both girls and boys. And in some countries, some high-income countries, Australia, the United States, New Zealand, I think they are already vaccinating boys. So the only reason why we are not vaccinating boys in Zimbabwe is about the cost. So if you are someone who's managing limited public health funds, you look at where you are going to make the biggest impact. So cervical cancer is the commonest cancer that is killing women in Zimbabwe. So obviously the biggest impact could be in preventing cervical cancer. That's why girls have been prioritized in terms of vaccination. But yes, I think funds permitting, boys can be vaccinated. So for those people with some money to spare, actually they can get the boys getting vaccinated in private. But I hope at some point we'll get to a stage where we're able to vaccinate both boys and girls. Yes, the vaccine works in boys. So the issue is just about managing the limited public health funds and trying to make the biggest impact in preventing cervical cancer. That's why only girls are being vaccinated.
All right, thank you for that response. Those who are coming out as anonymous, I think it would be great if you can show your names also so that we can see who's asking. An important question from Dr. Nyaradzo Mgodi. Dr. Mgodi, welcome, and we love your participation. Thank you, Dr. Guja, great presentation. Do you think the WHO global strategy to eliminate cervical cancer will be hastened by a more robust HIV response? The curves you showed take into consideration HPV vaccination and screening. My question is, do you think elimination will be faster with better HIV control? So this one you can answer, I think, as a standalone question because it's got several bits to it.
Thanks a lot, Nyaradzo, for that very, very interesting question. And so the way that I would address is, maybe I would like some other HIV clinicians to chip in here. So what we are seeing, I think there's been a lot of money has been put towards HIV control. And I think what we are seeing now is we are seeing women living with HIV living much, much longer because their HIV is well controlled. So when I'm seated in my clinic, I hardly come across a woman who comes and their viral load is high. So these women that we mostly see in our clinic, these are women that have their HIV under control, but now they're living much longer and they're now starting to present with these HPV-related cancers. So I would like to think that I think we've done very well. Of course, there's always room for improvement in terms of HIV control. I think a lot of work has been done, and I think that has been kind of like a success story to some extent. So I think the issue now is that these women are living longer, and we are not seeing them dying from cervical cancer. So I think we need to kind of like to pour in the same resources that we poured in terms of preventing HIV infections to try and reach the same to get kind of like to the same magnitude of also preventing cervical cancer. I'll be happy to have a comment from some of the HIV clinicians on the call.
Thank you for your response, Dr. Guja. If there is anybody who wants to add something to what you've said, they can raise their hand and speak, or they can just type in the chat box. Meanwhile, we continue with the questions that are already typed in the chat box. There's one from Dr. Billiard Tapesana, who says, I noticed that the WHO is recommending screening from 30 years, but we are seeing some sexually active adolescent girls and young women living with HIV also getting positive lesions in their 20s. What is the guidance on encouraging screening in this group? And that can be answered together with a question from Lawrence Munemo. Can circumcision help to reduce HPV in men? And then the other question is how accessible is the vaccine to women above 15 years? Is it readily available at the clinics currently? And we can allow those in policy making and implementation to answer that bit as well. So Dr. Guja and others, over to you.
Okay, so I think the guidance for women living with HIV is to get them screened from the age of 25, and for women that are HIV negative to be screened from the age of 30. So I think the problem in screening very early is that you're going to pick up a lot of background noise. Like one of my slides there, I alluded to the fact that HPV infection is very, very common in younger women before the age of 25. So if we start screening women very, very early, we're going to pick up a lot of HPV, a lot of lesions that we're probably going to regress on their own. And we end up doing a lot of procedures on these young women. And these procedures, actually, there are studies that have showed that, for example, doing lips, cone biopsies is associated with adverse obstetric and some other sexual or reproductive outcomes. So it's trying to strike a balance between not overdiagnosing conditions that are going to regress on their own and screening women who actually have lesions that have got a potential to progress to cancer. So for women living with HIV, WHO is going to move towards the age of 25. And I think there's no evidence that has been shown that yearly screening in HIV, women living with HIV makes a difference compared to screening them every 3 years. So WHO now recommends that as long as they've got good virological control, they're screened from the age of 25 and every 3 years, not every year, like what is currently happening. The question is whether about women that are above the age of 15 years. Unfortunately, the ministry is not supporting vaccination for women above the age of 15. They're just supporting vaccination for 9 to 10-year-old girls in primary school. I think it's all to do with the availability of funds. So for girls or women above the age of 15 who want to get vaccinated, I really encourage them to go and see their healthcare practitioners. Of course, you get a prescription, and then the vaccination can be done privately. And then the other question is, yes, there is some evidence that circumcision will somewhat reduce the risk of HPV acquisition. But I think by and large, I think what makes the most difference is to getting eligible girls, women, and boys are vaccinated for HPV, against HPV.
Thank you for your responses, Dr. Guja. I don't see any new questions in the chat box, but because we still have some minutes, I will ask if there is anybody who wants to ask or who wants to say something, including our important stakeholders from the Ministry of Health and Childcare and people working in other partner organizations or our sponsors from ZHI. If you really want to say something that you think is burning, I will give a few minutes for that.
Thank you very much, Dr. Grant. I don't know if you can hear me.
Yes, I can hear you. Thank you.
Thank you so much. My name is Emmanuel Tachwenyeka. I'm with ZHI. And many thanks to Dr. Guja and yourself for the comprehensive presentation. I noted in the presentation that the country recorded very high HPV vaccination coverages among adolescent girls. Would you have any innovations that were specifically implemented that resulted in us achieving such high coverages? And the follow-on will be around any specific challenges that you noted during implementation of this HPV vaccination among adolescent girls. Then send back to you.
Thank you, Mr. Chwenyika, for that question. Dr. Guja, over to you.
So I think one of the biggest successes, number one, is that if you look at what the statistics that I showed was, I think HPV vaccination was actually introduced in every district. So that means the girls didn't have to move from one district to the other to get the vaccination, to get vaccinated. And there are different models that can be employed to deliver this vaccine. And I think because I think our school attendance, primary school attendance in Zimbabwe is very high, and Zimbabwe opted for the school-based model in terms of vaccination. So I think that kind of like made such a big, huge difference because they were able to capture all girls that are actually going to school. But one of the biggest challenges is that for those girls that are not going to school, probably they're going to be missed by this vaccination. So I really think that there's still room for improvement in trying to get to the community, identify girls that are not in school, and getting them to be vaccinated. So a number of studies are being done to see how we can actually get these girls in the community that are not in school getting vaccinated. So some people have, some studies, one study that has been done in Chidamoyo was to try and see whether getting into the community and trying to introduce or promote HPV self-sampling, and at the same time for those women who are undertaking the HPV self-sampling, then asking them if they've got any eligible girls to be vaccinated who are not in school. And when the mom gets HPV testing, and you also identify those girls and getting them to be vaccinated. So a number of studies are being done to try and see how we can actually get to those girls that are not in school. So I think that is one of the weaknesses in that if you're not in school, probably you'll be missed by the vaccination. So there might actually be a need of a catch-up program to try and mop up all these girls and vaccinate them. And I think with also funds permitting, I think a lot of countries did catch-up programs for women and girls between the ages of 15 to 26. That would be something that would be very helpful in trying to improve the uptake of the HPV vaccination.
Thank you, Dr. Gusha, for that response. It's very comprehensive. I think for Mr. Chwenyika, what's really of note is that countries that have achieved the greatest success as far as uptake of HPV vaccination is concerned are those that have robust school-based vaccination programs. And so that's really the way to continue going this for us and for many of our other counterparts in sub-Saharan Africa. So another question, and this is not necessarily directed to Dr. Gusha, but anybody else who feels that they can answer this is, how can we engage traditional healers so that they work with health practitioners in managing clients' diagnosis of CA cervix? Some clients still believe that they can be cured of CA cervix with traditional herbs.
Thanks a lot, Grant. I will take that, then I'll ask someone else to give a different perspective. But I think one of the challenges that I've seen in practice, both in public and private health sectors, I think is the issue of costs with the treatment of cervical cancer. So remember that the partners are involved in terms of screening. But once the diagnosis has been made that someone has cervical cancer, then the partners, they don't fund investigations, and these investigations can be costly. So at the minimum, the woman would need to be seen by specialists at Parenya, where they pay about $15 US. After that, they're going to be asked to get some investigation, some bloods. They're going to be asked to get at least a chest X-ray, abdominal and pelvic ultrasound scan. That costs some money. And like I've highlighted, more than 80% of these women will need to be treated with concurrent chemoradiation. We know that radiation therapy has not been working in Zimbabwe for the past 1.5 years. And even prior to this 1.5 years, it has been working intermittently on 1 month, off 2 months. And also chemotherapy is not readily available in the public health sector. So most women have to buy the chemotherapy. So for me, I'll be able to get what other people think. And I think it's something that would be very, very worthwhile to explore in a qualitative research is, do people go to these ngangas or faith healers because they don't have anywhere else to go to? So if you are given a bill in private for radiotherapy costing something like 11,000, I think people are left with the option of just trying what is available. So I'm not sure it's a case of a chicken and egg. Is it that people are going there to the ngangas and faith healers because they believe what they are being told, or they have no option because they can't afford to get treatment in the public sector? I'm happy to hear what others think about that.
Thank you, Dr. Gusha. Any comments? Actually welcome. You can unmute and speak if you want to comment with regards to that or anything else as we get close to ending this meeting. And there is another question that just came in. Are there any targets set in cervical cancer screening at national level, that is MOHCC, that can show us that we are on track as a country in terms of cervical cancer? That's from Lawrence Munemu. If anybody is also available to answer this question as well, you're welcome to do so.
So I would say, Grant, I think if you look at the published literature about screening uptake in Zimbabwe, I think only about 30 to 20% of women are getting screened. And I think the target now, I think that was initially set by the minister, was around 50%. But if you are now trying to go through what WHO is recommending to eliminate cervical cancer, I think the target that we should be setting for ourselves is around 70%. So I think one of the challenges is that most of the partners that are doing screening are targeting HIV, that are targeting women with living with HIV. But I think most of these programs are PEPFAR funded, and although they don't turn away women that are HIV negative, I think they are mostly interested in women that are HIV positive. So I think that is somewhat, to me, that has been one of the challenges, because women that are HIV negative, probably they don't go regularly to the clinics, and probably this message is not getting to them that they also are also at a risk of getting cervical cancer. So I think there is a need to have a program that attracts both, targets both HIV negative and women living with HIV, so that all of them can also access screening. So 13 to 20%, I think we're still very way, we are still very, very away from reaching the target of at least 70% as recommended by WHO.
Thank you, Dr. Guja. Thank you for your presentation. Thank you for your responses. Thank you to everybody who contributed, and thanks to everybody who also attended this very important webinar. We are coming to the end. I think this is a call to action for all of us. We've got a role to play. Those of us who are in research and academia, those who are involved in prevention, treatment, communication, raising awareness, funding, I think we all have to work to do. Let's work collaboratively. We are fighting the same enemy, and if we join hands together, we will definitely be able to deal with this problem. So I hope for more webinars to raise awareness like this, but apart from these webinars, we actually hope for more action on the ground to deal with this problem, so that we can improve our screening coverage, we can adopt more effective screening methods, we can make treatment for precancerous lesions widely available for our patients, and we can also make treatment for invasive cancer affordable, accessible, and within reach of the majority of our patients, regardless of their economic status. So this is really work for us. But allow me to thank ZHI for inviting myself and Dr. Guja to take part in this important webinar. ZHI is really grateful to PEPFAR, who's the funder through USAID. Also very grateful to the Ministry of Health and Childcare, the Ministry of Primary and Secondary Education, the National AIDS Council, its implementing partners, and its rights holders, and everybody who was involved in cervical cancer prevention and treatment in this country. We meet again in other programs, but for now, thank you very much and enjoy your night. And thank you very much to Dr. Guja for your presentation. Goodbye.